Welcome to the surgical demonstration on hysteroscopic polypectomy using hysteroscopic seizures. We begin with a transabdominal ultrasound showing a well-defined hyperechoic lesion within the endometrial cavity, suggestive of an endometrial polyp. Note the central vascularity and well-preserved endomyometrial junction, which is typical features supporting a benign etiology. This patient is also having left side benign ovarian cyst, more often features suggestive for the endometriotic cyst. Well, we can use the salpingography to delineate exactly the polyp. So, in this case, we can go for an hysteroscopic polypectomy. For this, we require the spinal anesthesia is good enough, and after speculum insertion, cervical stabilization, gentle dilatation may be done. We are using a 4 30-degree hysteroscope with a 5 French working channel and normal saline at the distension media with a set pressure of 80 to 100 millimeter mercury. Initially, the hysteroscope is introduced under direct vision and the cavity is assessed, the entry wall, the posterior wall, both the ostia, and the presence of the polyp and with a stalk with a smooth surface, visible stroma, vascular pattern, confirm the sonographic findings first. Then hysteroscopic seizures are introduced through the working channel and always look and plan where to cut the polyp. So this seizures is introduced and under steady visualization, these seizures are positioned at the base of the polyp stalk. Always go step by step and always look for the path. You can just press the polyp and look for the stalk and reassess the stalk and again cut it. With gentle and precise cuts, the stalk is severed without the use of the electrosurgical energy, ensuring minimal endometrial trauma. There is minimal bleeding which settles spontaneously. If at all there will be small bleeder will be there, it will settle spontaneously. The detached polyp is retrieved using ovum forceps and the specimen is removed intact for histopathology. Of course, it must be subjected for the histopathology. The patient was an infertile patient. So this will be a blessing for her and this will be the treatment, almost the treatment for her infertility cause. We should avoid curettage, preserving the endometrial integrity, especially in the infertile patients. In postmenopausal lady, we must curate and the sample must be sent separately. The endometrial sample and the polyp sample should be sent separately for the histopathological study. We must be very patient enough to cut the polyp stalk and orientation and reorientation should be done so that the polyp will be detached. Now the polyp is detached completely and the remaining polyp stalk may be again recut, and this is the small bleeder as you noticed which will settle automatically. Then the removal by the ovum forceps. The cavity is re-examined and the ostia, both the ostia should be looked for. The entry and the posterior wall, this is the polyp peeping through the cervical canal. Then we can take it through the ovum forceps. The small ovum forceps are very helpful. So a bit of dilatation is required to introduce the ovum forceps. So this is a very good rewarding. So this is the polyp which is removed completely. Again, the reassessment of the cavity is done post procedure for the completeness of the removal. So this almost finishes the procedure. Thank you very much for watching this video.